Hello everyone, thank you so much for checking out this video. My name is Mark Velasquez and today I'll be illustrating a technique for ACL reconstruction utilizing a bone patellar tendon bone autograft. The authors for this video project are Dr. Andrew Dold from Star Orthopedics and Sports Medicine, who performed the procedure, and myself, who was present during the surgery, responsible for videography and production of this video. As a pre-medical student, I was compelled to do more than just the typical shadowing and observing in the operating room, but contribute in any way I can in orthopedics by showcasing this ACL technique. Producing videos like these is what I see myself doing in the future as a physician myself. So I'm grateful to Dr. Dold and Baylor Scott & White for giving me the opportunity. My first video that was released in 2020 was the left knee with the same technique, and now over a year later, we are performing the same procedure on the same patient but on her right knee. So we'll go right into the technique overview. As you can see here, this is the outline for the procedure, which will be mentioned throughout the video. Once we begin the diagnostic arthroscopy in step 4, you will be hearing Dr. Dold dictate and walk you through the procedure. We'll go ahead and present the patient case and history. Patient is a 17-year-old female with past surgical history of left knee ACL reconstruction, presenting to the clinic with recent non-contact pivoting injury to her right knee at basketball practice, onset 2 hours. She felt her knee buckle with immediate pain and swelling. She was unable to bear weight, and she was given crutches and referral to orthopedics. On examination, she had a positive anterior drawer test with a grade 2B Lockman's exam. Furthermore, pivot shift exam was positive and x-rays were negative. An MRI was ordered of the right knee to confirm ACL rupture and rule out other internal derangement and pathology. Both x-ray and MRI are shown respectively. AP and lateral radiographs were taken of the right knee, which did not show any obvious pathology. There is no Sagan fracture, and alignment is relatively neutral. An MRI was ordered to view the patient's right knee, which shows a classic bone contusion and bruising pattern line with the recent pivot shift injury. Moving into the intercondylar notch, we can see that there has been complete disruption and tear of the ACL. The PCL is intact, and there is no obvious meniscal pathology in either the medial or lateral compartments. The radiographs were reviewed with the parents and patient in detail, both deciding on an ACL reconstruction by way of bone patellar tendon bone autograft with meniscal repair versus partial meniscectomy as indicated. The operation was conducted on April 8th of the year 2021 at Baylor Scott & White Sports Medical Center, the Star in Frisco, Texas. We will be going into our first step of the procedure, which is the exam under anesthesia. We begin the procedure with Dr. Andrew Dold examining the right knee with the patient under anesthesia, positioned supine on the operating room table, padded well with a tourniquet on the upper thigh in place. We are assessing the range of motion. Lockman and pivot shift tests were both positive. LCL, MCL, and pulse exam. Valgus stressing is produced on the right knee at 0 and 30 degrees of flexion. Here are the incision markings from a previous repair as I mentioned before. A 2% chlorhexidine gluconate antiseptic solution is well applied on the patient's right leg to prepare the skin for surgery. Proper markings of the incision are centered over the patella tendon, approximately 5 to 7 centimeters, extending from the distal pole of the patella to the proximal portion of the tibial tubercle. With a positive examination under anesthesia, the bone patellar tendon bone graft harvest has begun. A 7 centimeter vertical incision is centered over the medial aspect for the patella tendon dissection. The incision is taken down to the level of the peritoneum. Proper care of the knee is done to elevate both the medial and lateral tissue, which have been created to visualize the lateral border of the patella tendon, as well as the proximal tibia and distal patella. A cauterizer is used to burn or dissolve the overlying tissue. This will catalyze the process to visualize the peritoneum. As you can see, the knee is flexed to 90 degrees to put the tendon under tension, and proper care is done to establish a viable layer for closure.
I'll take nets.
Now that we can visualize the peritoneum, an incision is made on the midline of the tendon. A 10 mm double blade is used to harvest a 10 mm section of patella tendon from the central middle third. They are utilized to create both tibial and patella bone blocks. Graft harvesting retractors are placed on both flaps to expose the tendon for the bi-incision. Now that our bi-incisions are complete, an oscillating saw is used to harvest the bone blocks. The saw is brought to a depth of about 10 mm. Later on, incisions are made to form the size and shape of the bone blocks, and an osteotome is used to complete the bone cuts.
Our graft. Good. You show it as well?
We go now to the back table to begin step 3, which is graft preparation. If I remember correctly, we are looking for a 28 mm tibial bone block and a 23 mm patella bone block. As you see here, he is contouring the bone plug for it to fit into the 10 mm femoral and tibial tunnels that will be made later on. Dr. Dole likes to use a series of crimpers for a 10 mm graft to shape both the tibial and patella blocks for implantation, so we can make sure that they fit into the 10 mm size for drilling. It is important to fashion the bone to allow it to fit into the tunnels once again.
Got number 2, number 5, and then number 5. Okay.
Proper sterile technique is demonstrated by placing the graft into normal saline before inserting into the tunnels for fitting. It is merely a process of trial and error when it comes to fashioning for the appropriate size tunnel. Readjustments are made until the graft can precisely fit through the tunnel display. After fashioning the bone, a drill is used to place holes through the patella and tibial bone fragments so sutures can pass through tensioning of the graft.
Which one is this? Number 2 or number 5? Number 2.
After drilling holes, a single number 2 passing suture is placed through the patella bone block.
Needle? Yeah.
And then the number 5 sutures are placed through the tibia bone block.
Okay, so this is our BTB graft. You can see this side's from the patella, which we just have a number 2 stitch to guide it through. And on the tibial side, I drilled 2 holes, each with a number 5 suture. The reasoning being is that this is the side we're going to tension on, and I certainly don't want this to cut out while we're tensioning. So I do 2 holes with 2 sutures for the tibial side of the graft. You can see on the patella side, I want about 23 millimeters of bone, and you can see that is almost exactly right at about the 23 millimeter mark. So we're just going to mark where that is. And from there, what I do is I determine that I always think that there's going to be 25 millimeters of graft in the notch. So I'll mark my 25 millimeter mark down from where the patella bone block is going to be in. So there's 25 millimeters. And then from there, I've got 40. First measuring how much is going to be in the patella, and we've got about, end up drilling about a 24 for the patella. We've got 25 in the notch, and then I can see that I've got about 40 on the tibial side. So I want my tibial tunnel to be 40 millimeters, which will allow me to put in a 30 millimeter compression screw without any of the screw being in the notch. The last thing we do here is we've got this 200 cc's, which I mix with 1 gram of vancomycin powder, and I just let the graft go in there, and we'll let it soak in a sponge while we prepare the knee. Diagnostic arthroscopy of the patient's knee. We're in the patellofemoral joint. As you can see, the cartilage looks great. We're going to flip our eyes to come down the lateral gutter here. looking for any loose bodies, which we don't see. That looks good. Come back around the top of the knee and go across into the medial side, looking down the medial gutter. No loose bodies there either. A little bit of a medial plical band, which you can see right there. And then from the patellofemoral joint, we flip our eyes just to look down here and come down. And there you can see that's a little bit of a cyclops lesion. So that's a torn ACL, and then an empty lateral wall sign over there where the ACL should be inserting into the lateral femoral condyle. So a little bit of a cyclops lesion there. From the intercondylar notch, we can go underneath the ligamentum here and then into the medial compartment. Give a little bit of a valgus load on the knee here. Have a look at the medial meniscus, which looks pretty good. And then I take my time with this part because I only create one portal, anteromedial portal, which I use for my diagnostic arthroscopy, but also for drilling the femoral tunnel. So I like to make sure that this is in the right spot. So I take my time sort of finding this and then going, using the spinal needle and sort of going as low as I can to the meniscus. That looks pretty good. And then I come across the notch here and flip my eyes back around just to make sure that I'm going to be able to get a good spot there for drilling. And that looks pretty good to me. You can see the old ACL footprint here on the lateral femoral condyle. And the main thing here is you want to avoid touching the medial femoral condyle there. So you can see that does avoid, it gives us a good spot. It's pretty low on the medial side. It's avoiding the anterior horn of the meniscus. So I like that. I'm going to take it. So we switch this out. You're going to see the 11 blade coming into the knee there. There it is. We're just going to make a small portal here. Always looking at it to make sure that we don't touch the medial femoral condyle and being real careful to avoid any damage to the anterior horn of the medial meniscus. And that looks pretty good to me. So from there, we'll take our shaver. I'm just going to clean up some of this ligamentum to help us see. Take out this cyclops lesion. So there you can see the cyclops lesion going. I'm taking out a little bit of fat pad here just to help with our visualization. There you can see the remnant ACL. We're going to leave a little bit of the tibial footprint here to help with guide pin localization. But I want to get as much of this old ACL out of here. Always with my blade protector turned back towards the PCL. So we don't damage the PCL. And there you can see a pretty good look of our PCL right there behind us, which looks great. So this is just working away on that lateral femoral condyle in the notch, getting rid of all this soft tissue here to help prepare our tunnel and for visualization. So a little bit of a notchplasty here. The main thing for me when doing this is for visualization. I try to take as little as I can, but the most important thing for this for me is when I'm putting in the graft, being able to see my tunnel and visualize the screw going into the tunnel. So I think that's probably fine. I won't take much more than that. So this is our radio frequency ablator here, which is good for the soft tissue as well. It's also got a 50-degree curve, so it allows me to sort of see when I'm behind the back wall, which is also important. So I'm just taking out the rest of this soft tissue here. Okay, let's go back to the bone cut and shaver. So this is another shaver coming in here. We're going to go on power. So this is just for preparation of the notch. Getting past residence ridge there. Let's have a probe. Okay, let's see a probe. Okay, so that's a look here at our prepared lateral wall. You can take a probe and sort of find your way around the back wall there. I think this is pretty good visualization. So our tunnel is going to be sort of as far back as we can get it. Generally for drilling a 10 tunnel, I use a 6.5 millimeter over the top guide, which theoretically will maintain 1.5 millimeters of back wall back in here. And we wanted to get it low and far posterior. So our tunnel is going to end up being around here. And I think that's going to be a good spot. We've got a good line of sight here through our intermedial tunnel, so that's going to be pretty good. And to the right here, you see the PCL, which looks pristine. Okay, so we're going to continue on just with our diagnostic arthroscopy. Give me a little fulcrum there, Taylor. So back here into the medial compartment, we're just going to assess the medial meniscus, which looks great. No tears, using the probe to get under it there, trying to get back and see if it can be probed in, which it can't. So that's a normal looking medial meniscus, which looks great. And the medial femoral condyle also looks perfect. So from there, we're going to go back into the notch. I'm going to flip the leg up into figure of 4 position and gently come in. We'll get our assistant just to elevate the leg for us a bit. Good. And then we come into the lateral compartment of the knee. I'm going to use my probe again here. So there's my probe coming in. Lateral meniscus, again, looks very, very good. Check out the horn here, the attachment of the root. And that all looks really good. So this patient is lucky she doesn't have any meniscal pathology. That all looks really good. We'll see if we can see popliteus at the back there, or maybe underneath the posterior horn here. Yeah, okay. But that looks like a normal meniscus. A little bit of fraying there on the, get the 3.5 on there. So a little bit of fraying there on the lateral condyle, which I'll sort of just hover my shaver over just to make it look good. And that looks great. So we get a picture of that, and that looks great. And then come back into the notch. Okay, so now we're ready for our ACL to drill our tunnels. Let's have the over-the-top guide. So Taylor, you're going to keep the foot here. Okay, so you're going to first let me come in. Okay, So here's our guide. So you can see this is a 6.5 millimeter over the top guide coming in. And what I'm going to do is sort of put it in a spot where I want, trying to extend the leg a little bit for me, Taylor, other way. Yeah, good. So I want to make sure this goes around the back wall. It's low and it's far posterior, so make sure the hook is on the back there. I think that's a pretty good spot right about there. Okay, so now you're slowly going to flex up the knee. So keep coming. The foot's going to go flat on the bed here, hyper flexed. Keep going, keep going. Good. Yeah, so there's the foot hyper flexed to about 120 degrees. We're in a pretty good spot there. There's some soft tissue, but that was fine. Actually, let's just get that out. Yeah, just stay there, that's fine. Okay, you're gonna drill this for us, okay? So pin all the way through. So come on back, Taylor, a little bit. Give me the guide again. We'll do that all again. Okay, so from a semi-extended position here. So there's our guide. So this is the 6.5 millimeter over the top guide. You can see it there. So I'm going to get that in a spot with the leg in this position, and I like that. So it's low and it's far posterior. Okay, so now my assistant's going to hyperflex the leg. Just wait for that. So what we do is we get the foot flat on the bed, and that puts the knee into about a 120 degrees flexed position. I really like where that is. We'll just confirm that we're back there. Yeah, that looks really good. So now we're going to come in with our beef pin and just check it. Yeah, I think that's in a great position. I'm going to sort of angle it up a little bit. Yeah, that's perfect. Go for it. Go for it. So this beef pin is drilled out the lateral thigh. Good. And it's going to exit the lateral thigh anterior to the intermuscular septum, which it has there. Going to keep drilling that. That looks pretty good. The main thing here is that we don't move the leg because you'll bend the pin. So a little trick that I do here is I flip my eyes to look back, and I'll ask for the soft tissue protector. And then to avoid damaging the condyle, I'll slide this tissue protector in like that. And then this is now a 10 millimeter fluted reamer that's going to come into the knee there. And then once you've done that, you can take out the soft tissue protector. Good. Hold the drill for me. And then I'll just flip my eyes back. And there you can see our drill. The knee's still at 120 degrees flexion to avoid blowing out the posterior wall. And again, we measured 25, so we're going to drill this to a depth of about 25 millimeters. Good, stop there. Hold that for us. Jen, give us a flush. Go behind the camera, yeah. Good. So there you can see the numbers are at about 20. We're going to go a little bit more. No, don't do that. Don't do that. So there's 25. We got a couple more millimeters to go. That looks pretty good. Hold there for us. Just make sure that... Yeah, so that's at about 25. I think that's perfect. Good. Okay, so let's get... So we give us that shaver. Put the 5.5 on now. You can... I got the leg. Yep. I'm just going to pause for a second. Okay, recording is back on here. So we're going to... This is our 5.5 shaver going in here and just sucking out all the debris from our tunnel. And then can we do our suction trick where we put the suction tip over? Yeah, let's do that. So this is a little trick here where you slide the suction tip over your guide wire, which puts it right into your femoral tunnel, and you just sort of suck everything out there a couple times. Just save some time from having to get all of this stuff out underneath. Put the suction on there once more. Yeah, just leave it on. Yeah. Good. There. So that's a pretty good look at our tunnel. Okay, so let's get our passing suture. Good. Okay, mallet. Yeah, you hold that there, Ronnie. Good. Okay, so this is our passing suture. We just tap it in. You can pull it all the way out there. Good, just watch it doesn't stab anything. Good. Beautiful. So let's get a snap. Got it here. Good, snap that. So here's the scope coming in from the other side of the knee. There's a little bit of debris back in there, which we'll get out. It's a pretty good look at our tunnel. You see we've maintained the back wall, and that looks like it's in a really good spot there. Get a picture. Okay, so the last thing I do for the femoral tunnel is just using the shaver here. I just bevel the anterior aspect of the tunnel just to take the edge off of the tunnel aperture here to avoid any sort of friction or rubbing that might damage the graft. So I use a 3-5 bone cutting shaver for this, and I just take this edge down slightly. That also might help with passing the screw. So I just bevel the anterior edge here of the femoral tunnel. That looks good. There's our tunnel. Suck it out a little bit more. And that looks great. Okay, should we notch? Okay. Let's get the notch here. Okay, you're gonna do this for us there. Shaver with 5-5 on. Grasper, arthroscopic grasper. That's what it should look like when the suction goes on. Yeah. So this is just a look here at the notcher coming in for helping us get the screw in. So I'm just going to put that about right there, and then get my assistant to go tap, tap, tap. Knees held at the same position it was when we drilled. Good. Yeah. Yep. Good. And I like that. It just allows us to get our screw started a little bit easier. I just make sure that little piece of bone is out of there. And that looks perfect. Okay, let's move on to the tibia now. Okay, so onto our tibial tunnel now. This is the radiofrequency ablation device here. We've left some of our footprint here just for guide pin localization, but I'm just going to clear it out here using this device. So anterior horn of the lateral meniscus is right there, so we're coming just off that and maintaining a little bit of gap here between the PCL and our ACL. So I think that right there is going to be a pretty good spot. We'll just sort of clear that out for our pin. Let's get the shaver. Okay, let's do it. So we're gonna get let's get our Army Navy ready to go. So we really have to retract over like that. Try and go on this side of the periosteum, just like that. That's perfect. Okay, you're gonna need to let me get in though first, and then sort of real low. So remember, we need 40, okay? We've got it at 55, so let me just get in there. Good. Okay, so here you can see our tibial guide coming in here. We've sort of marked our spot here, but I'm going to get it right where I want it. So I think around there is going to be pretty good. So that's just off there. You can see the posterior aspect of the anterior horn of the lateral meniscus. So we're going right across there, centered sort of in the notch. So I think about there is going to be a perfect spot. So some of this is, so allow them to come into the leg there, just past the skin. Yeah, good. So let me just move that a little bit medial to back it out a little bit for me. Ron, back it out a little bit, and then, okay, and now push it in there. Yeah, what does that measure? 35, 40. I'm gonna go down a little bit right there. So something like that is going to be good, I think. That's about 40. Perfect. So let me just make sure I get this in a good spot. But Ron, get ready to go there. That looks pretty good. Sorry, say that again. Yeah. Good. Okay, let me just make sure I like that. Yeah, I like that spot a lot there. Okay. So a couple of things. So we've set this to 55 degrees here, our guide pin. Again, it's in a good spot there, which I like. We check to make sure we've got a nice distance. That measures 40, which is exactly what we were looking for. So my assistant here is going to give me the drill. And then I'm going to choke down on the drill to about 40. And then I can sort of drill freely without having to worry about us plunging. So there I'm on left about 40 millimeters, 4 centimeters. And you should see this exit right at the point. Good, so it's just about to come through there. So I'm going to unattach our guide pin here. Good, that comes out. Guide comes out. I'll take the drill again. And you're going to see the tip of our pin coming through right there. And I think that's in a really good spot. Good. Okay. Let's get our curved curette. And 10. So I use a curved curette over the tip of this. My assistant's going to hold that. It prevents the guide pin from plunging. We're going to look down. This is now another 10 millimeter drill. Yeah, good stuff. My assistant's going to put that on here for me. And then we're going to avoid the skin here. So I'm going to get that, just let go. Yeah. Yeah. Good. And we're going to retract that down a little bit. Let me just get in. Good. Okay, and now we're going to drill this tunnel. You're going to see the drill come through here. Perfect. There's the drill. Good.
Good. Nice. Okay, let's go 5-5, or what's that? Let me have that. So there's our tunnel here. We're just gonna take some of the soft tissue out. And then same thing that I do on the femoral side, I'm gonna do on the tibial side, and that's just to bevel this posterior aspect of the tunnel here a little bit with this bone cutting shaver, just to take off that edge as the graft turns to go across the notch. So I just sort of get rid of any sharp debris there on that posterior aspect of the tibial tunnel. Again, with this little shaver, and that looks pretty good to me. Just a quick look at the tunnel. That looks good. Across to our femoral side. Good. And then we take the scope up and go up the tibia, see across there to the femur. And that's our tibial tunnel, which looks great. Okay, suture grasper. Actually, let's just trim this down here. Give me Army Navy. A couple Army Navies. Give me the 5-5 shaver. Another Army Navy. Get the 5-5 on here. Good, thanks buddy. So one little trick I do, I take the shaver and I just turn on with suction, and I just sort of clean out the aperture here a little bit with the shaver. It just opens it up a little bit for me, and just allows us to visualize it a little bit better and avoid any hang-ups with the graft going through. So I just sort of clean out the aperture there nicely, taking away some of the periosteum and the fat that surrounds the opening. And I just do that just to help with passage of the graft. So there you can see the tibial tunnel, which looks great. Okay, let's go grasper for our tissue. We'll go 30 more minutes. Good. Okay, grasper. Good. Taylor, you're going to have to hold one side there. I don't know. You're going to hold that one. I'm going to pull it into the knee. So pull both ends of those. Good. Pull. One's going to be cut, so pull them. Pull, 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 pull. Give me some slack. Good. And now I'm going to grab it and come through here. Make sure you don't let go, Taylor. Good. Okay. Okay, we got our tap and we got everything. Good. We're going to make a little bit of a loop here. Okay, so there's our graft passer. Graft. Okay, good. Let's go lights on, guys. Good. Give me Metzabon scissors. Right, so we're going to pass our suture here. Okay, so we use our passing suture here. You're going to pull that all the way through there, Taylor. Good man. Keep coming out. Good. I've got the graft here. Let's go Army Navy. Good. So here's the graft going in. Good. Taylor, you're going to pull on that, okay? Slowly, it's going into the tunnel there. Hold on, hold on, hold on. This is just, you don't want to pull this because you don't want to break it out. It should just be smooth, okay? There you go. Keep going. Good. Okay, so that's in the notch, I think. So let's look at it from this side. So there you can see our bone block coming into the knee. If I can have a probe, I'm going to help direct this into the tunnel. So there's our bone block with our passing suture. Yeah, so slowly give that a little bit of tension. Okay, then don't do it. So there's two ways. It could be hung up here, and it could be hung up on this side. So we want to just make sure it's going to go free there, which it looks like it will. So now we got to do it here. So I try and do this. Okay, stop, stop, stop. Wait. Did it go? Okay, let's just turn on our water. Oh, there we go. Wait. There it goes. Good. Yeah, I think we're pretty good there. Okay. Yeah, that looks great, Taylor. Are you in there? Good. Yeah. Okay, so there you can see our graft is in the tunnel there. All of the bone is, you can see that we've marked it there, which is right at the aperture, which is what we want. There's the BTB, the tendinous part of the graft going across the notch. And there's where we've taken out a little bit of bone there to help with the screw going in. So the next thing we want is our soft tissue protector. So soft tissue protector comes in from the intermedial side. We're going to go guide pin now. This just protects the graft as we're putting in our screw. Here comes our guide pin, which we're just going to snug in there. Good, yeah, we'll tap that. So that's going to stay exactly like that to protect the graft the entire time we're tapping and putting the screw in. And in young patients with good bone, I think it's important just to, yeah, let's hyperflex the leg as we're doing this. Good. Nope, just stay there. Okay, hold on, let's do this again, okay. Get that out. So Taylor, you gotta be like right sort of, like just let go. Okay, so let's put the foot up and just leave it like that, let go a little bit. It doesn't have to be that hyperflex, just sort of like that, perfect. It should just stay by itself. Okay, so what we want is, give me the shaver first. Let's just clean this up so we can see. Yeah. Good. Good. Okay, so let's try again. What's our pressure at? Go up on the pump pressure a little bit, Jen. Go up to 50. Yeah. Okay. So there you can see our graft going across the notch here. So we use a soft tissue protector now. The knee's in the same position that it was. Yeah, you can go ahead. Same position as it was when we drilled. So that looks good. We've tapped a little bit, but I think that's going to be fine. Let's go with our screw. Yeah. So we're using this soft tissue protector the entire time the screw goes in, and this is just to protect the graft. So I think that's in a great position there. This is going to be a 7 by 23 millimeter biocomposite screw. It goes over the guide pin. I turn it as it's going in so it doesn't drag any of the soft tissue. And we're just going to slowly turn with an axial load. There you can see the screw going in nicely. Starts to get a bunch of purchase. So at this point, we're going to pull out the soft tissue protector. Good. And then we're going to pull the wire out now. Sometimes a little bit tricky. Good. Couple last turns. And that looks really good. And it's in there. Let's go tap, tap, tap on the screwdriver. Good. There you can see our screw in there with our graft, which looks great. And then with the Lee in full extension, you can see that we've sort of approximated quite well. That's the aperture of the tibial tunnel there where we've marked the graft. And you can see the BTB Autograft coming across the notch nicely with the leg in full extension. So that's pretty much it. We're just going to fixate the tibial side now. And that's an ACL reconstruction with a BTB Autograft. And that looks great. Let's see the shaver. And there you can see the graft pretty well. It looks awesome.
Millimeters of the bone plug sticking out, so we did that pretty well. I've got my 2 stitches here which allow me to really tug on the graft. I like to hold them in this hand and give a posterior drawer force to the tibia as we're putting in our screw. and I'm really pulling on that. You can see only a couple millimeters of the bone plug coming out, which is what we want. I keep the leg in about 15 degrees of flexion when I'm putting in my tibial screw. So our guide pin goes down like that into the knee. We'll tap this a little bit. So that's the tap. Good. We'll go back in with our guides. Good. Again, I'm pulling this about as hard as I can, and then using my hand to put a posterior drawer on the tibia. I know that we've drilled a 40 tunnel. I like to get this screw as long as I can, so this is a 30 by 8 millimeter screw. It's a biocomposite screw. Just make sure that that's right down there nicely without any screw head sticking out. And that's it. We take our guide pin out, so I just cut the sutures both at one end and then just try and pull them out. And then we'll just use our, let's just use the rongeur suction there, guys. Good. And we just use this rongeur just to clean out. We'll keep this bone just to smooth out the aperture there. Let's keep this bone. Get me good. So we try and keep this bone to use as bone grafting and for our harvest sites. Good. Give me this. Give me that. Yeah. Let's just turn that on. Yeah, that's great. Good. And that's it. Good. Good.
So just a final look at the ACL. So there's our graft. This is with the leg in full extension, looking down, making sure that there's no graft impingement there, and the leg can get into full extension, which it can there. And that's a great look at our final ACL. And that's it. That's an ACL reconstruction with a BTB Autograft. There's the graft, legs in full extension. Looks great.
To conclude the procedure, proper closing and suturing of the right leg vertical incision is demonstrated. First, the peritoneum layer is closed. Then the subcutaneous tissue. And lastly, the skin. After suturing, an antibiotic combination of amoxicillin and clavulanate is injected to prevent any underlying infection and sepsis. Appropriate dressing and sterile strips are applied. The patient is placed well in full ACE wrap, which is to be worn for a few days after surgery, or as long as the knee or leg has swelling. The ACE wrap should be removed after 9 to 12 days after surgery. Thank you so much for taking time into watching this video. Hopefully you took something away and learned about this particular ACL reconstruction technique. Go ahead and like this video, and I'll go ahead and list my contact information below. Have a great day.